Central hypersomnolence disorders present a distinct challenge in sleep medicine. Patients report a relentless, subjective exhaustion that dictates every hour of their day, regardless of their rest the night before. This timeline shows the paradox of idiopathic hypersomnia. Patients achieve adequate, unfragmented, and prolonged sleep, often stretching past 12 hours, yet wake completely unrefreshed. Unlike insomnia, the problem isn't quantity. The issue is severe non-restorative sleep paired with persistent cognitive impairment upon waking. Diagnosis relies on three specific clinical colors. First, excessive sleepiness despite sufficient rest. Second, severe difficulty transitioning to wakefulness. Third, persistent non-restorative sleep. Because these symptoms are highly subjective, they overlap with numerous other conditions. Patients with IH frequently endure years of misdiagnosis, often being told they suffer from clinical depression, chronic fatigue syndrome, or simply a lack of personal motivation. Separating this specific neurological pathology from a general psychiatric complaint requires objective data. Clinicians must rely on polysomnography, overnight sleep studies that record brain waves, oxygen levels, and heart rate to isolate the true mechanics at play. The nighttime clinical features of IH center on extended sleep duration and profound alarm resistance. Patients regularly sleep through multiple high-volume alarms or disable them without any conscious awareness. This line graph tracks alertness over time upon waking, showing a rapid spike. Patients with IH experience a stark deviation known as sleep inertia. The IH profile line flatlines in the low zone. Physiologically, this causes prolonged confusion and impaired motor function persisting for hours. In reality, this means patients might wander their homes, engage in fragmented conversations, or repeatedly fall back asleep in a state of severe disorientation, entirely unable to force their brain into an awake state. Once the severe sleep inertia clears, it leaves behind a trail of daytime symptoms. Patients experience persistent brain fog, memory impairment, and a sharp reduction in occupational productivity. To combat this, patients frequently attempt to nap. However, unlike in other fatigue-related disorders, naps in IH patients are strictly non-restorative. Sleeping during the day does not improve their objective alertness. This continuous cycle, prolonged nighttime sleep, followed by heavy, unrefreshing daytime naps, indicates that IH is a failure of sleep-wake regulation. The brain receives ample sleep, but fails to register it. The term idiopathic means the definitive etiology or exact biological cause remains undiscovered. However, the leading pathophysiological theory points to a severe dysregulation within the central nervous system's sleep-wake control mechanisms. This visualizes a neural synapse highlighting GABA receptors. GABA is the brain's primary inhibitory neurotransmitter, slowing down central nervous system activity. In IH, an exaggerated influx of this inhibitory signaling effectively overpowers wake-promoting pathways, suppressing normal cerebral activation. In this state, the patient's brain operates as though it is under the continuous, heavy influence of an endogenous sedative. The sedative brain model aligns precisely with the clinical presentation. The patient's underlying sleep architecture remains structurally intact, but the regulatory mechanism fails to initiate and maintain an awake state when required. Translating these theories into clinical practice requires a rigorous pathway of diagnostic exclusion. Before IH can be considered, clinicians must objectively rule out other causes: obstructive sleep apnea, severe medication side effects, and chronic sleep deprivation. This continuous overnight PSG hypnogram plots the patient's sleep stages over time. It confirms the patient achieves adequate sleep without microarousals. The crucial metric extracted is the total sleep time, or TST, which in IH patients frequently climbs past standard thresholds. A subset of patients fall under the long sleep time variant of idiopathic hypersomnia. These individuals objectively record 11 to 14 hours of sleep per 24-hour cycle, yet wake feeling entirely exhausted. Confirming an unfragmented, heavily extended total sleep time via PSG provides the essential foundation needed to proceed to the next phase of evaluation: Daytime latency testing. The Multiple Sleep Latency Test, or MSLT, is the definitive daytime diagnostic tool. It measures how quickly a patient falls asleep during a series of scheduled daytime nap opportunities. The critical differentiator is the presence of SOREMs, or sleep onset REM periods. A SOREM occurs when a patient transitions directly into dream sleep, bypassing normal non-REM stages. The diagnostic rule is strict. If the MSLT shows 2 or more SOREMs, the diagnosis shifts entirely to narcolepsy. An IH diagnosis demands the absence of significant REM intrusion. This table outlines diagnostic thresholds. For idiopathic hypersomnia, the MSLT requirement is a mean sleep latency of 8 minutes or less. However, this short latency metric is identical to narcolepsy. Both disorders present with profound daytime sleepiness. Secondary clinical features finalize the differential. Type 1 narcolepsy is characterized by cataplexy, which is strictly absent in IH. Furthermore, narcoleptic naps are short and refreshing, while IH naps are long and unrefreshing. Differentiating idiopathic hypersomnia from narcolepsy relies entirely on polysomnographic proof that the patient's exhaustion is a distinct regulatory failure rather than dysregulated REM sleep. Because the exact etiology of IH remains idiopathic, current medical treatments focus squarely on wake promotion and direct symptom management. This pathway outlines current treatments. First-line defense relies on wake-promoting agents modafinil and armodafinil. Secondary options include solriamfetol, pitolisant, traditional stimulants, and drugs targeting GABAergic pathways. Behavioral therapies like fixed wake times are supportive, but rarely sufficient without robust pharmacological support. Left unmanaged, IH poses severe risks. Persistent cognitive dysfunction leads to massive work impairment, profound social withdrawal, and critical driving hazards due to daytime sleepiness. Idiopathic hypersomnia is a chronic, legitimate neurological disorder. It requires structured, long-term clinical support and continuous monitoring to maintain patient safety and function. Accurate polysomnographic differentiation is the first necessary step. In sleep medicine, diagnosing the mechanics of sleep is only half the battle.